This video presentation and its accompanying materials are copyrighted by the American Association for Respiratory Care, AARC. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. As a registered participant, you are authorized to duplicate course materials for this program for each participant viewing at your facility. This presentation and accompanying materials can also be used by staff within the institution, but cannot be resold, distributed, or displayed for profit. Copyright 2017, all rights reserved. The following is a presentation of the American Association for Respiratory Care. Welcome to Current Topics in Respiratory Care. Today's topic is Coordinating Spontaneous Breathing and Spontaneous Awakening. Richard Kallet is a registered respiratory therapist and fellow of the AARC. He is the Director of Quality Assurance in Respiratory Care Services at the University of California, San Francisco, at San Francisco General Hospital Medical Center in San Francisco, California. Mr. Kallet discloses that he has served as a consultant to asthma and allergy prevention company Nihon Kohden, Hamilton Medical, and Philips Respironics.
Greetings. Today's talk is on coordinating spontaneous breathing trials with daily sedation interruptions and how you apply that in clinical practice. The objectives for today's talk is Objective 1, list the positive and negative impact of sedation and analgesia. Objective 2, differentiate patient-targeted sedation from targeted light sedation. Objective 3, identify the two main historical reasons leading to prolonged mechanical ventilation and ICU length of stay prior to the spontaneous breathing trial DSI protocols. Objective 4, explain why targeted light sedation practices might make the coupling of the SBT and DSI protocols unnecessary. So in terms of the presentation outline, I want to spend a little bit of time what I call the prehistory, or how did we get here to using daily sedation interruptions in spontaneous breathing trials. So this deals with difficult weaning as either being a pathophysiologic or an iatrogenic issue, and also the inherent problems of sedation and analgesia in the ICU. We'll then need to talk briefly about delirium and post-traumatic stress disorder, which are the major complications in this area. Different sedation practices to orient you to when we talk about the important clinical trials that have been done on sedation and their impact on spontaneous breathing trials in reducing the length of mechanical ventilation and ICU length of stay. What is probably most interest to you is pragmatic issues of how you coordinate the DSI with the SBT, and in the era of targeted light sedation, whether the DSI is actually an important component to this. And finally, the impact of DSI and SBT and targeted light sedation in a non-research setting. So in terms of the prehistory of a rational approach to discontinuing mechanical ventilation, the take-home message is two things. The two greatest impediments historically to past weaning practices have been overly liberal sedation practices coupled with overly conservative weaning practices. So giving a brief history of overly conservative weaning practices, there's a historical concept to this. In the 1970s, when intermittent mandatory ventilation was developed, it incorporated something of a gradual withdrawal of mechanical ventilation. And how this was done was to put an anesthesia bag with a continuous flow of gas through the ventilator circuit, and in between the mechanical breaths, patients could breathe spontaneously. And the idea was to drop the mandatory breaths down and let the patient take over more of their own breathing. What grew into this was also a philosophy about respiratory muscle function and how patients needed to be transitioned back to spontaneous breathing. And it morphed into a belief that was summarized in a statement by John Downs back in 1980 that almost all patients requiring ventilatory support for more than 24 hours develop discoordinated breathing. Now, this is something that is physiologically not true, and in some ways was a misinterpretation of some of the data they've seen or how patients presented with other problems. In the 1980s, when pressure support ventilation became available as a technology, The idea of a gradual withdrawal of ventilatory support was grafted on to how pressure support was managed and weaned. And in many cases, IMV was married with pressure support ventilation, where very often the pressure support breaths in terms of their tidal volume size and their peak pressure exceeded the mandatory breaths. But the weaning was the same. The mandatory breaths would be dropped down, and then the pressure support level would be dropped down. This created some controversy, and one of the things that was made this very clear was a statement by Francois Lemaire, in arguing that depending on the case mix of any ICU, the weaning success rate is usually higher than 70%, and that a prospective study that they did in their intensive care unit showed that 19% of their patients were mechanically ventilated for more than 24 hours, had a prolonged weaning time of greater than 2 days. And this summarizes some of the controversy that existed throughout the 1970s of a minority of people who said this was not a way to wean patients. You do not need to gradually withdraw because most patients can assume they're breathing without any problem. Well, by the mid-1990s to 2005, there was a flurry of prospective randomized controlled trials. The first time this was looked at in a disciplined, scientific way. And you can see on the slide studies by Brochard, Isengard, Esteban, Matrix, Fernandez, and Farias, where the success rate following a spontaneous breathing trial, wherein someone is just placed on either totally spontaneous breathing or very low levels of pressure support or CPAP, is allowed to breathe for 2 hours. And if they do not develop distress or severe tachypnea, they were given a trial of extubation. And you can see that 75% or greater of the patients had no problem doing this, and if they were extubated, never required the ventilator again. So this was a total contradiction to the practice that we had done throughout the 1970s and 80s and well into the 1990s. Now, the other issue that came into this is overly liberal sedation practices, and there are 3 parts to this. So the core issue is that agitation should not be regarded as a sedative deficiency, and it's critical that correctable problems be excluded. And the correctable problems are usually pain, agitation arising from that, hypoxemia, a discoordination with a ventilator, and those things need to be addressed systematically before we start either introducing sedation or increasing sedation. So the most common error is inadequate sedation or inadequate use of analgesics, particularly insufficient doses that are too infrequent in their scheduling, or reliance on ultra-short-acting agents. So patients were developing periods of pain with accompanying agitation that was difficult to treat. Now, the solution to this was to move to continuous infusions, where it gives you a more even sedation analgesia with less breakthrough. And the reliance on increased infusions, rather than supplementing infusions with PRN boluses, contributed to the problem. And I've seen this happen in my institution and others, where if you start an infusion of a sedative, it takes time to work. So if you started someone on a midazolam drip at 2, they were still agitated after a few minutes, you increase it to 4, it doesn't seem to help, you increase it to 6. And basically, the approach to this probably should have been to start with a baseline infusion rate and give a trial of supplements to see if we could bring the patient to a nice stage, rather than just continuing to go up in the infusion rates to very high levels. So the third part of this is the overly liberal sedation practices, that there's a gray area of critical illness. There is a minority of patients that require anesthetic doses of sedatives and analgesics. And these things are necessary to treat things like SARS or avian flu, or patients that have an open abdomen and very large abdominal pathology. And these likely increase the adverse effects. The problem is that that was applied to patients that really didn't need that. So there's more of global application of high sedation analgesic practices where maybe it wasn't as needed. in fairness, the problem with this, it's very difficult sometimes to separate pain from anxiety. It is a gray area. The other issue is that benzodiazepines can lower the analgesic requirements. Because there are so many adverse effects of high opiate doses, they try to find ways to conserve on opiates by using other drugs. And one of them is benzodiazepines do reduce the opiate requirements. And this is a seductive logic to this, that adding sedative infusions lowers the analgesic requirements. But when this was done historically, we did not realize the negative effects of benzodiazepines on patient outcomes. So to encapsulate this, we can think of sedation and analgesia in the ICU as the good, the bad, and the ugly. The good part is that sedatives and analgesia reduce the stress response by reducing pain, anxiety, and dyspnea. They therefore decrease oxygen consumption and CO2 production. They improve mechanical ventilator synchrony. Both of these things are extremely important in very severe presentations of critical illness. And it decreases the risk of harm, that if patients are under-sedated, if they're in pain, they may try to remove their endotracheal tube, they may pull out other catheters. And it also facilitates nursing care, that very critically ill patients require numerous interventions, and if the nurse is constantly trying to hold the patient down and prevent them from removing their tubes or fighting the ventilator, it's hard for nurses and for therapists to be able to do all the tasks that are necessary to improve patient care and improve outcomes. The bad part of this is that opiates and sedatives cause respiratory depression. That increases the length of mechanical ventilation. It increases the ICU length of stay. It also increases the risk of delirium, something that was underappreciated until the past 10 to 15 years. And it's estimated that 33% of all ICU admissions do have delirium. Sedatives and analgesics increase the incidence of hypotension. They increase the risk for ventilator-associated pneumonia. They increase the risk for ventilator-induced diaphragmatic dysfunction. They decrease the ability to assess patients. And in many of the studies that I'll go over, one of the findings was in the usual care groups, there were many more CT exams and MRI exams because they could not assess mental status, or if there's an increase in white blood cell count and fever, they weren't sure if there's an intra-abdominal pathology because they could not assess pain adequately. The other huge effect is with sedatives, or in opiates in particular, is decreased gastrointestinal motility, which increases the risk of ileus and increases the risk of sepsis. And also with very high levels of opiates and sedatives, if you acutely drop them and try to wean them, you have an acute withdrawal syndrome where patients actually develop seizures. And if that isn't ugly enough, the very ugly is that high levels of sedation and analgesia are associated with increased mortality, and there are prolonged psychiatric issues following hospital discharge or post-traumatic stress disorder. So delirium is a syndrome of acute cerebral dysfunction or acute confusional state characterized by a change in mental status, inattention, disorganized thinking, or altered level of consciousness. In some studies, it affects up to 80% of mechanically ventilated, critically ill patients, and as I mentioned before, is an independent risk factor for death. And there's a 10% mortality risk increase per day of delirium. So you can see that changing our practices to reduce delirium will improve outcome. So many factors contribute to the development of delirium. Obviously, as I just mentioned, benzodiazepines and opiates, but also antihistamines and common diuretics such as furosemide, and these work through a central anticholinergic effect. Systemic corticosteroids are included in that. You notice I have acute stress with an asterisk. The acute stress is a special consideration in trauma patients that I'll talk about a little bit later. But also, one of the things that we still have not dealt with in critical care adequately is that sleep deprivation and fractured sleep in the intensive care unit, where there are numerous procedures around the clock and a multitude of alarms going off. has a great influence on the development of delirium. So that is another problem that needs to be tackled. So I want to talk very briefly about post-traumatic stress disorder, or what I like to call a perpetual haunting. And that in patients who survive critical illness, we've made great advances over the decades where people that probably would have succumbed to their illness or trauma in the 70s or 80s are now making a recovery and being discharged alive. But there is a downside to that there are many psychological issues that come about. And post-traumatic stress disorder, how it plays out in patients that have survived critical illness, is an avoidance behavior towards seeking further health care, institutions, and procedures, a fear and preoccupation of future reemergence of illness, a hypervigilance and obsession with any somatic symptoms, a preoccupation with delusional memories of the ICU. And this is particularly troubling, that people had nightmares and they couldn't tell what actually happened, what is real and what is not real. And that is something that is particularly haunting for folks to deal with. Confusion, again, between actual and imagined incidences that happen in the ICU. But one of the most tragic things is social isolation, that by a fear of germs that might lead to future infection and future severe illness, many of these patients start to isolate themselves from social interactions out of a fear of that. There's also a sense of claustrophobia that develops in some patients related to memories of being restrained. And there's also an intense reactivity in some of these patients to sounds similar to those in the ICU. So you can see where even though someone may survive and be lucky enough to go home and resume their lives, there is a perpetual haunting that may go on for years because of the ICU experience and because of the effects of high levels of sedation. Now, before we can talk about the studies that have been done that are pertinent to our main discussion, we need to review some of the sedation scales of how do you adjust sedatives based on the need for treating anxiety. And the two most common ones on the left, the Ramsey sedation scale, which is a little older, and the more, I think more commonly used now is the Richmond agitation scale. And they run numerically, the Ramsey from 1 to 6, where 1 is anxious and agitated and restless. The sweet spot is 2 to 3, a patient that is awake, oriented, and cooperative but tranquil, or a patient that's sleepy but opens their eyes and responds to commands. Close to that is someone that at least has a brisk response and you can wake with stimuli. And then you get down closer to someone that is deeply sedated or almost an anesthetic dose, which is sluggish response to stimuli or no response to stimuli. In the Richmond agitation scale, you can see there's a +4 is combative, a -5 is again the deep sedation anesthesia level, and the sweet spot again being 0 to -1 to -2. You'll notice in the Richmond agitation scale, it's not operationalized the way the Ramsey is. There's nothing to actually define what light, moderate, and deep sedation is in terms of the response to stimuli the way there is in the Ramsey scale. But both of these scales are commonly used and they're an important tool for how sedation should be adjusted. So there are 3 common approaches to sedation, 3 strategies. One of the most common, one of the oldest, is patient-targeted sedation, where sedation is based on a clinician assessment of an appropriate level of arousal and comfort. And that is assessed by RASS or Ramsey scale. The issue with this is a potential bias, a conservative bias among clinicians about what is an appropriate level, and that perhaps it's too conservative. The change in our practice came about with the spontaneous awakening trial historically in 2000, and I'll go over that study in more depth in a minute. But basically, once a day, that all sedation and analgesics are stopped. The patient is allowed to wake up. If they're uncomfortable, we restart the sedation doses at 50%, but allowing someone to wake up also allows us to assess their opiate requirements. If in the process of awakening they become severely agitated, that trial is stopped and it's resumed. But at least this is a way to try to get a better handle on what a patient needs. And this was very much applicable to patients that were being managed with continuous infusions of sedation. Targeted light sedation is the newest approach, It uses a Ramsey scale of 3, although it can be used with a RAS scale, but to try to get the patient into that sweet spot that I talked about before, where they're awake, calm and tranquil, or at least kind of drowsy but arousable. And then rather than starting with infusions, try to rely on boluses, small boluses of sedation, and repeat that up to every 5 minutes for 2 hours to try to get control over agitation. At that point, if it doesn't work, is to start infusions at low doses, continue with the boluses, and slowly go up. So you have a much more conservative approach with targeted light sedation. The problem with this is a practical one. Even if the nurse-to-patient ratio is 1-to-1, for the nurse to go every 5 minutes and check out more drugs to give a supplement, it can get in the way of patient care. But at least it probably represents an ideal way to approach sedation issues. As I mentioned before, the landmark study for this was by Dr. Kress in 2000. It was a medical ICU study of 128 patients with a good mix between ARDS, sepsis, and obstructive lung disease. Now, this was not a weaning trial per se, it was a daily sedation interruption trial to look at sedative and analgesic use. So both sedatives and analgesics were interrupted until the patient was awake or uncomfortable, followed by an evaluation of requiring sedation. Following the evaluation, those requiring sedation were restarted at 50% and titrated up or down afterwards. And the same, having the patient awake, allowed a better assessment of pain requirements. The control group, the sedation interruption was done only at clinician discretion. And you can see in the yellow that we have the DSI group, and in the purple, the control group. And then each of these mechanical ventilation days and the ICU length of stay were lower in those patients that received the daily sedation interruption. Now, there was another study of daily sedation interruption by Carson in 2006, which is essentially was a comparison between using benzodiazepines, lorazepam, versus propofol. So this again was another medical ICU study with a nice breakdown in patients, 40% with ARDS, 20% with septic shock. But these patients required at least 48 hours of mechanical ventilation, and they had to have at least lorazepam doses of 10 milligrams per hour or an equivalent of another sedative agent. So very high levels of sedatives. So the lorazepam group got boluses 2 to 4 hours, every 4 hours, and supplements, versus propofol at 5 mics per kilo up to 80, titrated every 10 minutes. They targeted the same Ramsey score of 4 for a brisk response. There was a separate protocol to cover analgesic needs, and the DSI was performed in both groups. Now again, in the yellow is now the propofol group, and the purple is the lorazepam group. And rather than mechanical ventilation days, what you see, VF days are ventilator-free days. So within a specific time period, did patients in one group or the other have more days off the ventilator breathing spontaneously? And you can see that the patients in the propofol group had a much greater time off the ventilator and a decreased ICU length of stay versus the lorazepam group. So this has led to the popular management choice of, rather than relying on Ativan, of using propofol to manage critically ill patients. Now, the study that's most important for this particular discussion is marrying daily sedation interruptions with SBT trials by Tim Gerard in 2008. This was another randomized controlled trial with much larger numbers, over 300. But again, it was a medical ICU study. We'll talk more about the implications of that later. And we had daily sedation interruption plus spontaneous breathing trial versus usual care and a spontaneous breathing trial. It was patient-targeted sedation, which was the first strategy I mentioned, where the clinician decided what level of Ramsey or RAS score would be used. And the case mix of very high, 50% of the patients had ARDS, only 10% had obstructive lung disease, 15% had cardiac issues. The DSI, all sedatives and analgesic agents were stopped. The DSI was defined, positive DSI, as opened eyes to stimuli or tolerance of 0 sedatives for 4 hours. And at failure, like the other studies, you restarted at 50% of the dose and titrated up or down. So if we look at the results of these, the yellow being the married DSI to SBT versus usual care with SBT in the purple, that ventilator-free days were greater when DSI was married to SBT, which translated into decreased ICU length of stay. Coma rate was less, incidence of coma days was less. Interestingly, delirium was not different between these groups. And that's probably based somewhat on the fact that it was targeted sedation, where the clinicians rather than the researchers determined what Ramsey scale would be appropriate for these patients. So taking a closer look at this, what was it about patients that had the SBT and DSI married together that was better than just doing the SBT alone? And if we look, starting from the left, move in one to just the SBT trials done, you can see that 81% of the time, the group that was married, the SBT to DSI, it was done, and 87% of the time the SBT was done when these things were indicated. And that kind of suggests that not having them coordinated allowed the SBT to be done at a higher rate because it didn't require coordinating this with nursing care. If you look to the left of that, the appropriate use of where sedatives were held when the SBT was done in the intervention group, that 90% of the time when the SBT was done, the sedatives were held. And for a randomized controlled trial to have that amount of fidelity to a protocol is very, very impressive. This is not something that's easy to do in clinical trials. You'll also notice, and this is an effect of studies, that when there's an intervention, people in the control group sometimes get the same intervention, and that 31% of the patients in the control group also had the sedation held. So there's a little bit of leak over in terms of practice. If you look to the middle and the SBT pass rate, they were identical, which is interesting. If you look down from that to the larger graph on the bottom, days to pass an SBT, they were identical. So marrying a spontaneous breathing trial with daily sedation interruption did not improve the SBT pass rate, and it did not improve the number of days it took to pass a spontaneous breathing trial. If you go to the right, the reintubation rate was essentially the same, and you go to the far right, the self-extubation rate was higher in patients that had the DSI. And we've seen this in our institution and others, that if patients are more awake, kind of agitated, the endotracheal tube is extremely uncomfortable, patients are likely to rip the tube out. So that is just one of the downsides of this. A closer look, when patients got the SBT, the incidence of tachypnea was the same. The incidence of respiratory distress, although not significantly different, was higher in patients that had the daily sedation interruption. They were more aware of their breathing sensation and the work that goes into that. So there was a higher sense of respiratory distress, and that probably led to the higher rate of self-extubation. Hypoxemia, though, was not different between the groups. Acute mental status change was the same in each group. Bradypnea, or slow respiratory rate, was very close. The only thing that was significantly different was a higher rate of dysrhythmias in the daily sedation SBT group, which was probably related to respiratory distress and a catecholamine response to that distress. So why is it that patients who received a spontaneous breathing trial with daily sedation interruption had less days on the ventilator? And as it turns out, patients in the daily sedation SBT group were more alert on the day of the SBT was passed, and clinicians therefore felt more comfortable extubating them. 54% were extubated in the DSI SBT group versus 40% in the spontaneous trial usual care group. And the issue of mental status is kind of a tricky one. The bottom line is that if the cranial nerves are intact and the patient can protect their airway, it's probably safe to remove the endotracheal tube, although clinicians are not necessarily comfortable with this. So the decision to extubate someone is different from how you wean someone. So that probably explains the difference in the study's results And the interpretation of that is that it's necessary to marry these two approaches together. My feeling is that it isn't, but what I will show you in the bottom of the slide, the graph, that those that were in the SBT-DSI group had a lower 28-day mortality and a lower 1-year mortality that was significant. So whether this was related to sedation practices, I can't say, but it is interesting, and it is something that should be taken seriously, that marrying the two protocols together did, at least in this study, end up with better results in terms of mortality. Now, the evidence of does a targeted light sedation married to a DSI protocol versus just managing patients with targeted light sedation, does that make a difference? In other words, if we maintain patients at a very light level of sedation, do we actually need to do a daily sedation interruption and have to coordinate that with respiratory care? So a study out of Toronto by Mehta in 2012, it was an even larger study of 430 medical and surgical ICU patients. The overwhelming amount were medical. Benzodiazepine infusions were to a comfortable yet arousable, so the Ramsey and RASS scores that we had talked about, the sweet spot. The DSI assessment was the patient being able to perform 3 out of 5 simple commands. And again, like the other sedation studies, a 50% restart of sedatives in patients that required it, and an SBT protocol. And you can see from this in the bottom graph, the yellow being the targeted light sedation plus DSI versus targeted light sedation alone. There is no difference in the incidence of delirium. Again, remembering delirium is caused by numerous issues, including fractured sleep, use of Lasix, and use of steroids. So it's not just sedation itself, but delirium was not different. The reintubation rate was not different. Hospital mortality was not different. And if you look to the graph on your right, the length of mechanical ventilation, the ICU length of stay, and the hospital days were all the same. So the implication of this is that if we maintain patients with targeted light sedation, we don't need to use daily sedation interruptions. The patients are already at a very light level. So one other study I'd like to talk about briefly came out of Scandinavia, the Strom study. And this was kind of a demonstration of whether sedation needs to be needed. It's kind of a demonstration of principle. So this was a study of analgesia without sedation, a rather small study in comparison, 113 patients. Again, 90% medical ICU, but 5% trauma. The treatment group got 2.5 to 5 milligram boluses of morphine sulfate. And rather than a sedative agent, they got a comfort coach. So they had a person at their bedside besides the nurse that was constantly there to interact with them, to try to keep them calm, to keep them oriented, and to assess their needs along with the nurse. They had an early mobilization protocol, an SBT protocol. The control group, rather than having a comfort coach, started at 20 mics of propofol, titrated to a Ramsey of 3 to 4. They also got a daily sedation interruption with a restart at 50% that we've talked about in the past few slides. The interesting thing is that after 48 hours, if they still required propofol, they were changed over to a midazolam infusion, which might have muddied the results. But these patients also had early mobilization and SBT. If you see on the graph on your right, the yellow being the no sedation group, there was a significant reduction or significant increase in ventilator-free days in the no sedation group, which translated into a decreased ICU length of stay and translated into a decreased hospital length of stay. The caveats for this are, number one, morphine and other opiates have a sedative effect. More importantly, 18% of the treatment group crossed over to continuous sedation, and they did so for severe ARDS. So while this is a proof of concept that patients may not need sedation as much as we think they do, patients that are very severely ill, this will not work. The most severely ill patients will need sedatives and analgesics. And again, the other thing is that the 48-hour changeover to midazolam might have skewed their results because we saw before that propofol and midazolam have different effects on the ICU length of stay and the mechanical ventilation duration. In the United States, the use at this point in time of coaches is impractical because of healthcare economics. The hiring the number of people that would be necessary for this is probably not practical, but it is something that we need to look at more seriously in terms of our use of sedatives and different strategies that could be used to reduce sedation use. So in terms of the practical aspects of if you're going to marry an SBT to a daily sedation interruption, how does this actually work? We've been doing this for many, many years at my hospital, and it's kind of a caricature, a bit of hyperbole, but I set up this scenario that if you have a 14-bed medical surgical ICU with 12 intubated patients, 8 of them meet or have already met weaning readiness criteria. 4 of those patients who had a previous SBT and failed, 2 failed one trial, 1 patient failed twice, and 1 patient failed 6 times and is hugely problematic, difficult weaning. 4 of the other patients, it's their first SBT trial. 3 of these patients have a 1-to-1 patient nursing ratio. 5 of them have a 2-to-1 patient nursing ratio. 4 of the patients, the ICU team is ambivalent whether they're going to actually extubate someone if they pass the SBT DSI. And 2 of the patients are also scheduled at some point during the shift for procedures, we'll say a CT scan, an MRI, or endoscopy. So how do you make this work? How do you marry these together from a practical standpoint as a respiratory care practitioner? My response to this, and in my experience, is you have to triage your patients. One of our responsibilities as therapists in the ICU is to maintain the flow in and out of the intensive care unit to try to get patients that do not need a ventilator, do not really need ICU care, to expedite their removal from the ICU and removal of therapies that keep them there. So the way I would approach this problem is I would look for anyone that's been ventilated for less than equal to 2 days. Those that have an unambiguous resolution of the underlying problem which caused them to be intubated, so let's say a patient with CHF or intraoperative fluid overdose that just needed some Lasix, someone that was in the ICU for prolonged recovery from anesthesia, patients that had an absence of neurological or neuromuscular issues, patients with reasonably low minute ventilation demands, good chest mechanics, there are no pending procedures, no pressors. Those are the patients I would target because you're most likely to have a high success rate in passing the SBT, and it's more likely that the physicians will extubate that patient. The lower priority would be those that have been extubated for a longer length of time, but more importantly, those that have an ambiguous resolution. They have ARDS, they do meet weaning readiness criteria. As I put a few bullet points down below, perhaps their minute ventilation demand is still high, their chest mechanics are not that great. Patients that are post-arrest, post-cardiac arrest, or sepsis tend to be more difficult, they have more problems, so they're more likely, even if they pass the SBT, physicians tend to be more cautious about extubating them. Anyone with pending procedures can get in the way of that. And low to moderate pressor rates, although that is technically doesn't fit into the category of weaning readiness criteria, very often that gets violated. Whether that should be done, patients that require low doses of pressors, it probably is safe to wean and extubate them. But in clinical trials, that wasn't done, but that's something that'll probably be looked at more closely later on. Who actually needs anesthetic levels of sedation and analgesia in the ICU? And there's a concept of the golden hours of critical illness, similar to the golden hours of trauma resuscitation. And this is based on the fact that severe infection and trauma, which often leads to ARDS, results in a profound inflammatory state that is believed to be maladaptive. In other words, before we had critical care medicine going back since humans existed, if they were the victims of severe trauma or massive infection, they would die, simply. And that the body's response is to go nuclear, this one last gasp of just pushing everything the immune system has to try to fight it, basically didn't work throughout history, But now that we have the ability technically to keep people alive for several days or weeks, the impact of that maladaptive response plays out. That therapies that perpetuate or amplify the inflammation during the early phase may tip the balance towards greater mortality. And we know as respiratory care practitioners, high tidal volume, high minute ventilation demand, which is the transfer of energy from the ventilator to the lungs at a high rate per minute, high driving pressure, the plateau minus the PEEP, hyperoxia, which melded together with high tidal volume amplifies the inflammatory response, severe patient ventilator asynchrony, because the diaphragm, when highly loaded, is a large generator of pro-inflammatory mediators, insufficient PEEP by causing shear injury. All these are likely culprits. So the more, let me put it this way, the less control we have over the ventilator, over the patient ventilator system when the patient's fighting, the more hypoxemia, the higher levels of PEEP, the higher tidal volumes to try to keep someone in sync with the ventilator. All of these steps may tip the balance. Again, they may just antagonize the inflammatory response to the point of no return. This is not a fact, this is just a suspicion that what we do in the first few days during this massive pro-inflammatory state may be crucial to outcome. And therefore, using high levels of sedation and analgesia to get control of the situation is probably necessary to improve outcome. However, I really want to stress this. It's only a minority of patients who need this. And trying to take this practice of generous analgesia and sedation to patients that are less severely ill is problematic. And the great thing about these studies that have been done that I've gone through is that the systematic approach of sedation scales, of keeping people at a lighter level, if at all possible, where pain can be assessed more clearly, probably contributes to better outcomes. We're not fishing around in the dark and guessing at what's needed. Now, one of the very important points is the ICU population characteristics where you work. Notice that the studies I talked about, they were sedation studies focused in the medical ICU patients. And the sedative requirements in trauma victims may be much greater than medical patients or those with surgical procedures that are planned rather than unplanned. And I want to emphasize on trauma that severe anxiety disorders often develop following exposure to severe stressors. In other words, if you are the victim of a motor vehicle accident, if you're assaulted, shot, or stabbed, there's an intense fear and helplessness, a horror that manifests in the ICU. In other words, a fight or flight response. God forbid if we're in a motor vehicle accident, we witness this, we experience it, we're in pain, we feel like we're going to die, we wake up in the intensive care unit. The fight or flight response doesn't stop. It goes on when that patient wakes up. It's magnified by the fact that that patient wakes up, all of a sudden they have a tube in their throat, which is extremely horrible. They're on a ventilator, they can't control their breathing, they can't communicate, they're restrained, they're in an unfamiliar environment with people dressed funny that are poking and prodding and constantly doing things to them. Those things greatly increase the stress and increase the requirement for sedation. So some patients, particularly trauma patients, probably cannot be maintained, at least initially, on very, very light sedation. There are other issues that are involved with this. So grafting on the results from studies done in the medical ICU with a different patient population need to be done a little bit more carefully in a surgical trauma population. With that, I'd like to also point out that critically ill patients with complicated psychiatric and drug abuse histories present greater challenges. And there are also, from studies done at my institution, that patients with psychiatric issues also tend to be a higher proportion of the victims of trauma. So where you work matters intensely on the approach to sedation and analgesia and how you can apply the studies I've talked about to your particular institution. So with that, I just want to spend a couple of minutes talking about the practical application of these and how these have played out in a major urban area public hospital level 1 trauma center, which is San Francisco General. So this is something we started in late 2007. We started our SBT protocol. 2008, we started DSI. In 2013, we began targeted light sedation. And I'm fortunate enough to have some data on this. In this slide, you'll see the mean days of mechanical ventilation before and after the implementation of the SBT-DSI protocol and targeted light sedation. So there's a separation you can see between year 2007 and year 2008. And you can see that before we did this, the average days of mechanical ventilation in our hospital was close to 6, which is consistent with the literature in the early 21st century. And you notice that after we implemented these protocols, and they weren't, they're not done perfectly, there's not perfect fidelity or very great fidelity like there are in randomized controlled trials, but we do the best we can with that. So even with that imperfection, you can see that there is a significant drop in the average days of mechanical ventilation that have been going down and hovering around 4. If you look at the standard deviation or the dispersion of the mean data, you can also see that the dispersion also went down dramatically. When we look at special issue patients at my institution that required greater than 30 days of mechanical ventilation, paying particular interest to the dark blue, that patients that required from 1 to 2 months of mechanical ventilation, that the number of patients, this isn't percentage, but the number of patients that require between 1 to 2 months of mechanical ventilation has also gone down. This is very profound. The changes in our practice have had a huge impact on patient outcomes. Even if we can't do this perfectly in a large institution and an academic center, if we make a good faith effort to do it, we can see results. So last, if we look at this in terms of patients with ARDS who represent some of the hardest patients to wean off the ventilator, that the duration of mechanical ventilation went down based on severity. If we use the mild, moderate, or severe Berlin definition, the average days of mechanical ventilation went down, and particularly those with severe ARDS dropped the most dramatically. I have a feeling that is because the patients that had more severe ARDS, there was probably a reluctance to aggressively wean their sedation down and move aggressively to SBTs. If we looked at it by ARDS etiology, we see the same pattern, that this protocol reduces the days of mechanical ventilation. These, by the way, are all survivors of ARDS. This did not include mortality. These are all patients that survived to hospital discharge. So in summary, many often unavoidable factors associated with ICU care increase the likelihood of delirium. It's not just sedative agents, but sedative agents are a huge part of the problem. Delirium increases the risk of death. It increases the likelihood of post-traumatic stress disorder. Generous sedative use is a substantial risk factor for developing delirium and post-traumatic stress disorder. The history of weaning and sedation practices have been the major culprits in this problem of delirium and post-traumatic stress disorder. And there's difficulty in differentiating pain from anxiety. This is not a clear-cut issue that we have to deal with. But the incorporation of DSI and SBT and targeted light sedation, along with other practices like early mobility and sleep promotion, are very likely to improve outcomes. Thank you.